So first things first, it's important to hold the transducer correctly. And the key is that if you don't hold it correctly, you're going to have difficulty in pivoting on a point, that is transitioning between the transducer being in this direction and the transducer being in that direction for your long and your short axis images of the needle position. So I'm going to show under the video, index finger there, thumb here. Notice that there's a little excrescence from the transducer. That's actually meant to attach a needle guide, but it serves as a nice opportunity to seat the thumb and have something to be able to turn against. The other two fingers are like yay, and we want the wrist to be in this relationship to the transducer. And the reason for that is that we need at times to be able to recruit the fourth and fifth finger to provide counter pressure as we're placing the needle. So first and foremost, it's important to hold the transducer correctly. Practicing holding the transducer and manipulating the transducer is a good thing to do. Okay, so as we approach the biopsy, I diagram everything out the night before, or at least come in early the day of the procedure. And graphically, I design it out, go through all of the previous written records, all of the previous imaging records, check to make sure everything makes sense, and I make up a worksheet that has my checklists as well as a visual representation of the targets. That's partially for me to keep me on track during the procedures so that we don't forget to do anything, and so that we're making sure that there's a one-to-one correspondence between what we need to do and what we've done. But it's also for the technologist, because when the tech positions the patient's head, and for right now this is going to be the head side, head can either be to our right or to our left. Now, what determines that? In essence, it's the position of the lesion. We want to have the lesion as close to us as is possible, so that we're leaning over the patient as little as possible, and so that we're staying in concert with Rule 3 for us, which is keep it simple. So a lesion which is in the lateral aspect of the left breast will result in the patient's head being positioned to my right as I approach the cart. And remember, we're doing all these procedures line of sight, so that the ultrasound machine is over here, I'm over here, this is my left arm, this is my right arm, and the big variable is whether or not the patient's head is to my right or to my left. So, to backtrack a little bit, if a lesion is in the lateral aspect of the left breast or in the medial aspect of the right breast, which is going to be out of the field of view for this video, then the patient's head is positioned to the right. If, on the other hand, the patient's lesion is in the medial aspect, we're going to rotate her, or actually put her on the cart so that her head is this way, her feet are this way. So right now, just in this illustration, we have it set up so that the lesion epicenter is in the lateral aspect of the left breast, so the head is to the right side, my right side. Okay, so as we set the lesion up, rule number 1 is that we want the lesion as close to us as possible. We want to be not leaning over the patient any more than we need to, in part for our back, but also in part because we respect the patient and we want as little intrusion upon her personal space as is possible. So the second thing is, as I approach the whole process, is that I'm looking at where are the vessels. If we're entering in from a lateral aspect, we always want to know where the lateral thoracic vessels are. Those are the big bad boys in the lateral aspect of the breast. The medial perforators, which I have cheekily named the McNamara vessels because nobody else named them, are going to be variable, projecting from the internal mammary vessels and coming more laterally. So if you can imagine jail bars, okay, we want to make sure that we're going through the jail bars if we're going to make an approach to a lesion in the medial aspect of the breast. We want to make sure that we're avoiding the lateral thoracic by either being over it, under it, but in any case away from it. And I've illustrated the lateral thoracic just so that we're always keeping in mind where that major vessel is. So, patient is positioned on the table, we've done all of our notes, we've diagrammed everything out. We come into the room, we go through our checklist, and the checklist will be as a part of another video. The patient is already prepped with ChloraPrep before we walk in the room. We're going to re-prep, yes, but she's already prepped, so that what we're doing here doesn't require wiping off gel and then again starting all over again and prepping them. So this lesion arbitrarily is going to be at the 12-15 position. Let's say that's 4 centimeters away from the edge of the nipple. As I approach it, I make sure that the screen is annotated correctly. I go to that geometric location, that GPS set of coordinates, as I begin to look for the lesion. So as I scan, I identify the lesion. I look at our diagnostic images and I do a template. I make sure that I have the correct lesion in terms of its size, edge configuration, echogenicity, and milieu, everything that makes up it. So if you imagine the Mona Lisa, everybody can visualize Mona Lisa's eyes, but we're not just concentrating on her face and her eyes. We're looking at all 4 corners of the image to make sure and check and double check with templating the fat planes that we are in the correct location. So we've identified by GPS coordinates, 12-15 position, 3.5 centimeters from the edge of the nipple, where we're going to begin to scan. We identify the target. We visually check the images that we are acquiring in real time with our diagnostic images to, again, lock in that we have the correct lesion. Believe me, if you don't do this, you will eventually make a mistake. Absolutely guaranteed. And you cannot make a mistake that I've not made. So that's how we learn. All right, so as I'm approaching it, I've identified the lesion, and then I'm going to start setting up the biopsy. So I'm going to identify the target. I'm going to look for any major vessels which might cause me to adjust exactly where I'm sampling that target. I want the best tissue. I don't want necrotic tissue, but I want to stay away from big bad vessels if I possibly can. I'm already aware of what vessels are in the lateral aspect of the breast because I've looked and I've checked and I've scanned briefly with color to identify what's where. So as I set up the biopsy, I'm going to identify the center of the lesion. So the mnemonic is, as we look at the screen and position our image, 1/3, 2/3 parallel to the floor, slide right, slide left until you see more. So in other words, what you want to do is make sure that you're identifying the epicenter of the lesion. As I'm setting up where to enter, I'm looking at what vessels are in the neighborhood. I'm also looking at the depth of the target. So for example, if the target is 2 centimeters deep, if I want my needle in real time to be 2 centimeters deep, then I either need to go along the convexity of the breast to allow for that 2 centimeter depth, or I need to come out a distance, at least a centimeter, 1.5 centimeters from the edge of the transducer, to then purchase the distance by entering at an angle and then changing the pitch, flattening the pitch, adding positive pitch so that the needle, as it advances towards the target, is going to be parallel to the transducer face. Critically important. So let's let's have a pretend needle here, and I'm just going to choose this pen, and we'll look at a couple of scenarios. So 1/3, 2/3 parallel to the floor, slide right, slide left until you see more. I have identified where my entry point is going to be, and just for fanciness here, I'm gonna make my entry point a little bit further out. I'm cognizant. Let me get a different color here. I'm cognizant of where the lateral thoracic is. So in this case, I'm either going above or below it. Probably in this circumstance, I would end up going above it. I've got the needle, and imagine yourself playing pool. So I'm holding the transducer. My body is angled to the cart that the patient is on. My left thigh is locked against the cart. I'm actually leaning against it a little bit, so make sure that you lock it. And the angle of my body is maybe 45 degrees with respect to the long axis of the cart. And the reason for that is that I'm going to be holding the needle like I would essentially a pool cue. All right, if you think of pool, those guys and gals, they've got it nailed in terms of how to use a stick-like structure and get that stick-like structure to go exactly to hit the round structure. We're doing the same thing. Stick-like structure, needle, round-like structure, target. So don't reinvent the wheel when the wheel has already been shown to us by our good friends Minnesota Fats and Jane Slim. So 1/3, 2/3 parallel to the floor, slide right, slide left till you see more. I've chosen my entry point, thinking about where the vessels are and also taking into consideration my depth. So let's say I've entered, I've changed the pitch, I'm advancing a little bit. I come out now, and remember, this is at depth. I come out along the line, pointing towards my entry point to pick up the needle. Now, if I don't see the needle, I'm going to look right straight down because the needle might be pointing out a little bit like this. So I'm going to pivot on a point. I'm going to find the needle. Okay, where is it? It's pointing over there. I'm going to come back. I'm going to pivot on a point so that I'm pointing to the entry point. Think of that as being a fulcrum. And then what I'm going to do is I'm going to put a yaw correction in so that I'm pointing now right towards the center line of the long axis of the transducer, which is aligned with the central portion of the lesion. I'm going to advance. I'm going to come out a little bit. Notice how I'm heel-toeing a little bit, just so I can get over it. I'm going to start picking up the needle, and then I'm going to work it, moving my left hand, and if I stop seeing the needle, I stop pushing the needle. Do not go like that, trying to see the movement of the tissue. In the breast world, we don't do that. The main reason for it, honestly, is we have very big, very sharp objects. Cause as little trauma as you can. You're therefore going to be holding pressure less. Plus, honestly, it's the more elegant thing to do. You don't need to back and forth like that to find the needle. So if we don't see the needle, it just simply means that the needle is not under the center of the transducer. So what I can do is I can come out, I can find it, say, oops, okay, it's more towards the patient's head. Here's the center of the lesion. I pivot on a point until I'm pointing to the entry site, and then I simply put in a yaw correction on the needle and advance it. The various types of needles that we use and when to select the needle and you know, which one you use in which circumstance we can do in another video. So for right now, it's just the generic video, and we're going to say that we're going just for the epicenter of the target. So we advance it, we get to the edge of the target, we take another image, We advance it or fire it so that it's within the target. We want to always make sure that we see the needle in long axis, the entirety of the needle, good specular reflections. If we don't see a part of the needle, or rather if we see only a portion of the needle, usually what it means is that we're off axis a little bit. So instead of the needle being a nice long line, we're only seeing a short line. Generally it means that we're off axis. If we're in the target, that's okay as long as we have nothing that is big and vascular that's going to be along that axis. But in general, our targets are much smaller than this illustration. So what you don't want to have is a small lesion. Let's put another lesion here. Let's say that's about 1 centimeter in size, in which the needle is like this and not going directly through it. So we'll have illustrative images. It's hard with this and just with a verbal description. So we'll do some PowerPoint images for you as well. So if, for example, you only see a small portion of the needle as a specular reflection, it means that either the needle is to the cephalic end or the needle is to the caudal portion of the lesion. On the ultrasound screen, those two circumstances look exactly the same, because whether you're crossing through the beam like that or you're crossing through the beam like that, the ultrasound machine would have no clue. So what we do in a circumstance like that is we pull back the needle. So let's say we're entering with at the same location. We're seeing that we only have a very small portion of the needle as a specular reflection. So what I do is I'm going to pivot on a point until I'm pointing right towards the entry. I'm going to pull the needle back, and then because I'm looking directly down on the needle, remember we do these as line of sight. Draw a line through my right arm, the needle, the transducer, the lesion, and the ultrasound image, all in line. I can just simply look down and put in a sufficient yaw correction that I'm pointing right towards the center line of the transducer. Then I can come out, find it a little bit, advance, 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 checking to make sure that I'm absolutely over the epicenter, and then guide it in so that I have that full specular reflection before I fire, or as I set it up with the lesion nestled in the collection aperture for one of the large core vacuum devices. So that's the basic gist. That's a little bit of an overview. We've run into 18 minutes here, and just like the TED Talks, this is where the hook comes out. They pull me off the stage. So I'm Dr. Mike McNamara, professor of radiology at Case Medical School, and I have the privilege of teaching our residents, and I owe everything to the patients and the residents. Thank you very much.